Good evening, everyone. This is Jeremiah Johnson. I'm the chair of the Young Neurosurgeons Committee. Today, we're on our Young Neurosurgeons NREF webinar entitled The Foundation, Why and How I Became a Spine Neurosurgeon. We have excellent guests and panelists today, so thank you for joining us. I always like to go over the goals of this webinar. For those of you who are new to the webinar, the goal of this is to provide students, residents, and young neurosurgeons with timely information, education, and inspiration towards a career in neurosurgery. So you might ask, what is the Young Neurosurgeons Committee? It's a group of elected young neurosurgeons, residents, medical students, and early career neurosurgeons who provide representation to the AANS leadership. We develop future leaders of neurosurgery and provide a channel for young neurosurgeons to impact the direction of the specialty. We also do things such as this webinar to help educate and inspire all folks interested in neurosurgery. So we are represented today at AANS. So what is the AANS, if you're not aware? It's an organization that was founded in 1931 called the American Association of Neurological Surgeons. It's a scientific and educational association with more than 10,000 members worldwide. As an organization, it tries to guide the field of neurosurgery. Its roles include education, advocacy, and promoting highest quality of patient care in our field. And our group is the Young Neurosurgeons group that represents a representative to the AANS. So this is the Young Neurosurgeons NREF webinar. So what is NREF? It's the Neurosurgery Research and Education Foundation. That is a non-for-profit 501c3 organization created by the American Association of Neurological Surgeons as a philanthropic arm. What they do is they support mainly financially through philanthropy, basic science, clinical research, as well as lifelong education to foster improved outcomes for our patients with neurological diseases. They do great work. There's a publication that Dr. Lonzer headed up that said that for every $1 that NREF has given to young neurosurgeon investigators, it's turned into $30+ of NIH funding for the field of neurosurgery, which is remarkable. They also fund a lot of the courses, hands-on courses that are currently not happening right now for the education of young neurosurgeons and residents. So hopefully this will fill a small portion of that gap, and we appreciate their support. I'll mention that we're not going to have a webinar next week, but on Thursday, December 17th, we're going to have a Ask a Neurosurgeon webinar where any of you guys who are interested to ask us questions, talk about neurosurgery or any particular topic that you want to have a chat about will be available. As some of these webinars have gone a little long and we haven't had as much interaction as we'd hope, this will be a fully interactive session. All right, to our featured guests. We have really wonderful guests today, Dr. Nicholas Theodore. He's the Donlin M. Long Professor of Neurosurgery and Orthopedics. He's the Director of the Neurosurgical Spine Center. He's the co-director of the Carnegie Center for Surgical Innovation at Johns Hopkins University at the Department of Neurosurgery there. He is well published, several hundred publications, book chapters. He's well known for his innovation work with the spine surgical robot, his work with the NFL, concussion and spine injuries, and it could go on and on. Dr. Theodore, it's a great pleasure to have you with us. Thank you for joining us.
Thank you very much, Jeremiah, and everybody at NREF. There's critical work, obviously, sponsoring people from an early stage. So the topic was going to be why I chose neurosurgery. I'm just going to start off by saying spine surgery is the best. So we're going to get that off the table here right now. No offense to my endovascular and cranial colleagues, but it's been an interesting evolution of how I got to where I am, and it's been a lot of fun along the way. And I think ultimately, really, it's all about having fun. And every single day, I tell the residents, if you're not having fun, it's not a good day. We have to, even though what we do is serious, and not everything goes the way we want it to, you got to have fun every day. I threw this in here. I may touch upon things where there may be a conflict. So, this gave me the opportunity, so they wanted some pictures. This gave me the opportunity to sort of go back in the retrospectoscope here. So this is 30 years ago. I was a senior at Cornell University. And what does a guy who's pre-med and a government major end up doing? Of course, he goes into spine, right? Because I wasn't smart enough to go into, cerebrovascular surgery. So, my degree was in government and had done all the pre-medical courses and ended up in medical school at Georgetown. And it was during that time that I joined the Navy. which is probably one of the best decisions I ever made in my life. The exposure that I got, leadership, and just a different way of looking at medicine and problem solving and interacting with people was really great. During medical school, the question comes up, well, what are you going to do? And early on, I was a little nerdy here when I decided I thought I was going to be a neurologist. So along those lines, spent a few months at Queen Square. I was completely hooked by this. And I realized really we weren't able to do a whole lot. And that the inability to be active in the treatment of patients sort of struck me. And I sort of got off that. And then ultimately ended up with looking at something like OBGYN and was loving delivering babies. And I remember calling home one day and I told my dad, I said, I think I'm going to do OBGYN. And he said, OBGYN, because people have been delivering babies for thousands of years in the world without help. What about neurosurgery? And I said, neurosurgery, I never even thought about it. And, decided the last rotation, third year was neurosurgery. And here I am today. And, along the way, had exposure to neurosurgery, both in the Navy and the civilian arenas, which was a lot of fun. And, graduation from Georgetown, just headed down the street to Bethesda Naval Hospital, where I started my internship, and had matched in neurosurgery in civilian world, and then realized that the Navy decided that wasn't going to happen. They wanted me to do some fleet time. So this was during internship. And even though I was committed and had matched in neurosurgery, the needs of the Navy were that I was not going to do my training right away, that I was going to spend some time in the fleet. And this was the Navy team at MedStar Hospital. We were exposed to trauma. And from after internship, I was shipped off to Okinawa, Japan for a year, where I spent time with the Marines. And really a transformative year, because it's a great break between college and medical school before a long and arduous residency to do something different. And the things I got to see and do, how many neurosurgeons get to handle C4 explosives and blow things up? It's a miracle. The guy who showed me how to do explosives was missing 3 fingers, and I could have been the only spine surgeon that has only 3 fingers. But things worked out. But it was really a very unique exposure and a great patient population to take care of. Got to make some very great friends along the way. Went on relief missions, and really was eye-opening in so many ways. At the end of that time too, was united with my wife now. We've been married for 26 years, and then that's where the journey sort of begins. But when I look at, how do people get to places, the thing I want to mention are mentors. We have mentors that we collect along the way, people that help guide us. And this is Ron Hargraves, who was a Navy fighter pilot turned neurosurgeon, done a fellowship at BNI, and really taught me a number of things. And the most important of which was taking care of your team, taking care of the people in the operating room, just like you would if you were a commander on a ship. And also the concept of not just being a good surgeon, but being a good physician. And taught me something called the aviator's prayer. I can't say it online here, but you can look that up. Something I say every day before I go into the operating room. And then early on at Bethesda, before early part of my training, I got to spend time with Ed Oldfield, who is really an icon in neurosurgery and really one of the most phenomenal surgeons and mentors I've ever had. And, he was sort of disgruntled when I told him I was going to be a spine surgeon, because, he said, spine surgery, really, it's not that great. He goes, but if you're going to be a spine surgeon, don't forget about the spinal cord. Make sure you still work on the spinal cord. And those are words I took to heart. I was blessed to be able to come to Phoenix to train, and with this gentleman, Volker Sonntag, who was one of the early icons in spinal surgery, and just a very decent and honest human being, but really taught me about being honest about our complications, owning up to our complications, being critical of ourselves, and the whole spirit of mentorship. How do we train the next generation of surgeons? And that's something I've taken to heart. At the same time, obviously, was this character here, Robert Spetzler, was the chairman of the department, who was really a technical whiz. And as I teach the residents, spine surgery doesn't have to be blood and gore and in and out. It really, there has to be obviously a delicacy to it also, and you can do things in a less abrasive and invasive fashion. And he really learned a lot about using the microscope and microsurgical technique. And then ultimately, this gentleman here, Mark Hadley, who's the spine chief at University of Alabama, really taught me about knowing the literature. We worked on guidelines together, et cetera. And he, it has sort of inspired me in this area of interest in cerebral or spinal cord blood flow, and has been a great friend and mentor. And collecting friends along the way. On the right, you see Mike Lawton, Cameron McDougall, and these are all sort of important. As I saw here, you guys talking to each other, you'd all train together. These are friendships which last a lifetime. So it started off when I was at Bethesda, and the reality was I realized that, we were doing like 10 aneurysms a year at the hospital. I was like, there's no way I was going to be a great vascular surgeon starting off at Bethesda, but spine was everywhere. And Volker Sontag came to the Washington Academy of Neurosurgery and gave an amazing talk. And I was able to come out and spend a year doing research and met this gentleman here on the right, which is Neil Crawford. And Neil and I became lifelong friends and started a company together, built a robotics company, and are still talking to each other almost on a daily basis. But the reality is that, we get taken in different directions for different reasons. And my, thought that spinal surgery was going to be the way to go, it was a very conscious decision. It was really made for a number of reasons. And, I think when you talk about spinal surgery, you have to talk about the breadth of the field. And really, there are congenital, degenerative problems, trauma, infection, and really a chance to innovate and change the way we do things. So it's really exciting, I think, because there is a huge interplay between engineering in that field, and really there are more than one way to do things. And I learn something every single day when I go to meetings and talk to people as we try to get better at what we do. So why do we subspecialize in neurosurgery? I think it's become increasingly difficult now. The era of the generalist is going to go away, which there's just too much knowledge base, endovascular, spine, peripheral nerve, et cetera. And the fact of the matter is that subspecialization, I think, is really the way of the future. And it really helps us be able to become an expert in what we do. When you look at, just the approaches to the lumbar spine, you realize that it's daunting, and it's become, with time, we've realized new corridors and new ways to do things. So again, there really is a lifelong learning process in spine surgery that allows us to adopt new techniques, push boundaries, move things, decide a different way to a different approach, and figuring out how we treat our patients. And just, this is where I am now. I made a decision 4 years ago after being in Phoenix for almost 20 years to come to Johns Hopkins. On the left in the yellow is the research building, on the right is the patient tower, and I'm nestled here in the green. And my office literally sits 50 feet away from what's called the Carnegie Center for Surgical Innovation. These are the operating rooms where Walter Dandy and Blaylock did surgery for 75 years. And, there's the OR bed being pushed into recovery. Now that same room is a hub for technology. And the same operating rooms have been transformed into a technology hub where engineers and surgeons work on a daily basis. I wanted just to show you a couple of cases, I think, representative of, not the more mundane, but some of the more exciting things that we do. And I think why spinal surgery for me is really the one of the most interesting fields. This is a 27-year-old woman who, comes in with severe right arm pain. Could it be a herniated disc, whatever? She's got good strength. She gets an MRI scan, and I get a call from the primary care physician in a panic. She's got this very large intramedullary tumor with associated syrinx. You can see this mass completely expands the spinal cord. And really, this isn't something that you probably want to sit on, or she's not just pain, but starting to develop numbness. And, along the lines of what, Ed Oldfield said, I think some of the most beautiful surgery is the spinal cord surgery, and the ability to take a lesion like that, which rests within the spinal cord, and, in a very, looks like our video is going to freeze here, in a very delicate fashion, being able to open those fibers and resect that tumor. And I think this is, again, this is why I think in spine surgery, we have it all. We've got instrumentation, we've got deformity correction, and we're also able to do things like this, taking out intramedullary tumors. These are post-operative imaging. Another case here recently, a 34-year-old woman who, presented with really sort of rapid progressive weakness in the arms and legs, or excuse me, the legs, I should say, the arms, with this compressive thoracic lesion, sort of odd, sort of spherical lesion. And again, part of it's like opening Pandora's box. You never know what you're going to find. And this turns out to be a dermoid tumor. And, again, delicate surgery. So it's not all about screws and rods in big cases, but we certainly are able to, and I still love to do in a large part of my practice, is some of the more delicate work. This is a young girl of 7 with spondyloepiphyseal dysplasia, short stature, and she's at school. She falls off the slide and becomes quadriplegic. She comes to the emergency room, and they send her home. They don't know what's going on. But if you look very closely here, there's a problem with the cranial-cervical junction. And when the flexion extension x-rays, basically her head is pivoting on this joint here. And with the CT scan, it becomes obvious that what we're dealing with is a chronic ununited fracture of C2 here, where the C1 is fused to the dens. And she's basically had injured her spinal cord. So this is a highly unstable situation in a child with very abnormal anatomy. So this is not somebody that has, normal anatomy where we can do a normal operation. And this is an operation that we really described and perfected in Phoenix, which is to make hardware for this patient. So that is an endotracheal tube stylet, and we're actually making what the curve is at her cranial-cervical junction, and from there passing a series of wires. And these children have markedly abnormal anatomy. So we're really sort of drilling, we're utilizing image guidance, finding corridors where we can actually pass wires, then passing that rod. And it seems like a whole lot of work and a spaghetti of wires coming out. But ultimately, as you sequentially tighten those wires down, you get a situation where you can, immediately stabilize the spine, because this is a child where you cannot get normal hardware in. So this is sort of what is exciting about our field, because there's a chance to do things differently. This is the post-operative result, the CT scan.
Tell me your name. And how old are you?
7.
And hopefully back to normal. And now we've got the even for routinely degenerative disorders now have the ability to use technology. So we're able to now plan, and with with robotics, be able to place pedicle screws. I've got it down now to putting in 4 screws for a single level T-lift in about 8 minutes, and doing this procedure in now under 2 hours. We started off, it was 4 hours, 4.5 hours. But we've been able to collapse the time of that procedure down significantly. But again, this is the marriage of technology, and it's going to work every day is exciting because we're doing something different every day. And this is something that has been an exciting part of my life. But just to show you that there is obviously more than one way to do things. And as we incorporate technology into our practice, this is the way. We don't have time enough anymore with the trainees to teach MIS surgery where we're shooting hundreds of x-rays. Robotics, image guidance is really helping us transform our field. And the last case is a young woman of 20 who I operated on about 2 years ago, had with low-lying conus, lipomyelomeningocele. This poor girl had intractable, horrible pain. And unfortunately, she'd had 5 previous detethering operations. And normally what we do is this, which is to go down to the bottom, lyse these adhesions, and ultimately the spinal cord still stays stretched. And in my experience, these patients don't really get a whole lot better for the long run. So one of the questions is, can we do something unique? Can we take out a vertebral body and actually physically shorten the patient? And we choose T12 because that's a neutral segment of the spine below the last dentite ligament. And as we do that, we actually shorten the vertebral column and take that tension off. So I can't get the spinal cord to come up from the bottom, but can we do something bigger operation, different operation to take that
tension? I remember
tension?
there were days in high school where I would literally be crying in class just because I was in so much pain, and there was nothing that could mask that pain. There wasn't a strong enough medication for it.
So it's Katura who decides to have the surgery. On the day of surgery, my resident calls and goes, Dr. Theodore, her pedicles are very small, and the pedicles are these structures here, which we want to put screws through. And I said, oh, I know they're small. And then I look at them, I said, yes, they are very small. But again, utilizing robotics and image guided techniques, we're able to take this, and you can see where we've shortened the spinal column here. And interestingly, what happens is this: you've got a stretch on the spinal cord. Spinal cord actually starts assuming a more normal diameter. This is before shortening, you see a little excursion of the spinal cord, just as an example on imaging. And then look at the spinal cord after the operation with that normal pulsation.
Every time I went in, like, hey, Dr. Theodore, I went and did a mile, almost became like a challenge to me. Like, what can I surprise him with the next time I go?
So this young woman really did amazingly well. And I think, I'd like to say that while everything we do has risk associated with it, just like this swing and a miss here with Mark Hadley pitching, we always swing for the fence. We want that home run. We want to hit that ball. And, I flied out that first round where this is 2011 at the championship softball game, and then end up hitting the game-winning home run. As you can see, there's the last guy out there looking for the ball. Dr. Hadley, my mentor, a bit dejected, but really it's not one person. As we know in neurosurgery, it's a team. And I think that part of being a spine surgeon is being able to not be a technical wizard, not be a genius, but to be able to effectively lead a team to affect outcomes for our patients. And those teams include not only the surgeon, but obviously everybody in the operating room and the rest of our staff, as we pull everybody together to affect these outcomes. So I think the journey has been exciting. Spine surgery, I think, is an exciting field. And there's not a day that goes by that I'm not thankful for my family and the ability to give me the ability to do this. And I would say that, if you want an exciting and varied life, spine surgery is the way to go. So Jeremiah, thank you for the opportunity to present to you all today.
That's great, Dr. Theodore. Thank you so much. That's a very concise yet thorough review and really, really wonderful. I'm going to share my screen here in a second. And while I do that, for any of the participants who want to ask questions, just put the questions in the question and answer section here. And we'll have plenty of time after Dr. Tan speaks to answer questions and chat with the guests and the panelists. Let me just share my screen here one more time. All right, next up we have Dr. Khoi Tan, who is an associate professor of neurological surgery and orthopedic surgery at Duke University. A little bit of his background, which I'm sure he'll cover, is you can see there. And one thing I want to point out with Dr. Theodore and Dr. Tan is that they both are former Young Neurosurgeons Committee members. And when I joined the committee, Khoi Tan was the vice chair, I believe, at that time. So that's how I got to know him. He did a wonderful job. We can touch base about our panelists, but I want to let Khoi share his slides, and then we'll go to our panelists just after.
There we go. Sorry about that. Well, thanks so much for the introduction, Jeremiah and Dr. Theodore. That was a great talk. Like Jeremiah mentioned, it's been a few years since I was a young neurosurgeon, but it's been great to see what you and the rest of the team have accomplished, including webinars like these. And I'm very grateful for the opportunity to speak. So over the next 15 or 20 minutes or so, I'll talk about why I chose spine surgery. These are my disclosures, but most importantly, the views in this talk are certainly biased because I, like Dr. Theodore, am very passionate about spine surgery. And so if I make a barb towards, brain tumor surgeons or vascular surgeons, it's not to be taken personally. So I was born in Texas and grew up in Portland, Oregon. And my first time away from home was in college, where I went to Johns Hopkins and was very fortunate enough to stay there for medical school. And kind of always wanted to be a doctor, but certainly entering medical school had no idea what I wanted to do. And, after the first couple of years of med school, the classroom time, I really found myself enjoying the neurosciences and I guess very much similar to Dr. Theodore, entered the wards pretty laser focused on becoming a neurologist, and had that path charted out. And at Hopkins for our surgery rotation at the time, we did 2 months, 1 month of a general service, and then 2 weeks of two different subspecialty services. And so I figured that since I was going to become a neurologist, I might as well spend a couple weeks seeing what neurosurgeons do. And during that rotation, completely, fell in love with the field. I love the fact that patients were presenting with, neurologic symptoms, but as surgeons, we were actually able to do something about it, as opposed to the mantra of, diagnose and adios. And so, quickly switched gears there. Had really, really great mentors at Hopkins, and was very fortunate to match at Michigan for neurosurgery, where I entered very sure I was going to become either a brain tumor surgeon or a cerebrovascular surgeon. Now, I will warn the audience that over a 7-year neurosurgery residency, you might lose hair and look like I do now, but definitely worth it if you're passionate about the field. And so, I became really enamored with spine surgery for reasons that I'll talk about, but also was really much thanks to great mentors such as Paul Park and Frank Lamarca, who were my primary spine attendings at Michigan. From there, went to UCSF to spend a year with Praveen Mamaneni and the team there. From there, was able to actually get a job in my hometown at Oregon Health and Science University, where I spent 4 years. And at that point in time, I really had a great opportunity to join the spine team here at Duke, led by Chris Shaffrey, who I think is one of the world's premier spine surgeons, the previous AANS president, and absolutely loved my time here in North Carolina so far. So let's just talk about, why spine surgery. And there's going to be many reasons, and we'll just go over some of them. Maybe, and I'll try to make this interactive. So maybe I can pick on, I believe Anna is on the line and is a medical student. So, the first point here is that spine surgery is critically important to the field of neurosurgery. So Anna, if you were to guess, if you were to take a look at all neurosurgery cases that are done, in the United States, what percent are spine and what percent are cranial?
Well,
just a guess.
I am from Mexico.
Oh.
So I don't know, maybe I'm gonna guess right now. I really have no idea, but half of them, maybe. I don't know. I really don't know.
Yeah, that's fine. That's a great guess. And brain surgeons like Dr. Johnson certainly get all the glory, but spine surgery actually makes up 70% of all of at least American neurosurgery. And so what I tell the students is that if you want to become a neurosurgeon, just make sure that you don't hate the spine, because chances are you're going to do a lot of spine surgery, not only during your training, but also as part of your career. I think a great thing about spine surgery is that there's always people to help. So when you look at the incidence of neurosurgical disease, a lot of the things that neurosurgeons treat are actually, orphan diseases. So look at the incidence of some of these things that we spend time with. So glioblastoma, the incidence is 0.003%, right? Parkinson's is a little bit more. Hydrocephalus, still a little bit more than that, but still less than 0.5% of the population in terms of incidence. That's the number for Chiari. Aneurysms a little bit more, 2% incidence. Back pain incidence, so more than 10%, per year. And if you look at, the entire population, at least 80% of people, I think probably much higher than that actually, will have back pain at some point in their life. Now, granted, a very, very small minority of those people actually need surgery for their back pain, but you'll see with spine surgery, there's a lot of different things that we can treat, and basically never run out of people who are able to help. Spine surgery actually requires extensive knowledge of anatomy. If you're a brain surgeon, this is what you're focused on. But if you're a spinal neurosurgeon, you actually have to know about all of this as well. And when you look at spine surgery, it actually changes from level to level. So it's not like brain and then, the spine is just one big structure. I would argue that each of the 30 bones of the spine are completely different from each other, more or less. That's a bit of exaggeration, but you know, C1 and C2, for example, is here on the left and the right, respectively. Two completely different bones, completely different ways to instrument them, high stakes. I always tell the residents, I see some of them online here, that C1 and C2 screws are really the two screws where if you're not careful, you could kill somebody, right? If you're too far anterior with your C1 screws, you could hit, you could bag someone's carotids. With both of these screws, as well as the rest of the cervical spine screws, you could hit someone's vertebral arteries and leave them significantly debilitated. And C1 is different from C2. C3 through C6 or C7 are fairly similar. But even within the thoracic spine, this isn't exactly the way I teach it, but I essentially break it into upper, middle, and lower thoracic spine, each region being subtly different from each other with a different way to safely put in instrumentation. And obviously, cervical and thoracic completely different from lumbar spine. And so to become a spine surgeon, you could rely on navigation, but I think to really do justice to your patients as well as to your trainees, you have to know this anatomy. You need to know, how to put in instrumentation safely, and each level is at least a little bit different from the next. And that makes the job, pretty fun. Like, for example, today I did a sacroiliac joint fusion with Dr. Theodore's robot. This was followed by a minimally invasive laminectomy and synovial cystectomy in the lumbar spine, followed by a revision cervicothoracic fusion. So really fun day, got to do a wide variety of things. And within spine surgery, there's a wide variety of pathologies that affect the spinal column. And Dr. Theodore listed these, but include degenerative, deformity, trauma, tumor, infection, vascular, etc. And so just a few cases. This is a degenerative example, an example of something relatively easy that spine surgeons treat that really benefits patients. But a 32-year-old woman who came in with right leg pain for the preceding 1 year, and she had failed all forms of non-operative therapy, medicines, PT, chiropractic, acupunctures, injections, intact on exam. But what you'll see on her MRI here is a pretty large L4 to L5 disc herniation that's clearly more compressive on the right and causing her right leg pain. And so these days we can treat these patients with minimally invasive approaches on the right, where we essentially create a 2-centimeter incision, dilate the muscles so that there's really no muscle stripping off of the bone, remove a small piece of bone to get down to the ligamentum flavum, the nerve, the disc herniation, and then remove the disc fragment that's pressing on the nerve. And, this is an example of a easy case that we do. That's probably the most common surgery that spine surgeons and general neurosurgeons do. It takes about an hour, usually at max, with pretty minimal blood loss. These patients go home the same day, usually with their leg pain gone, and it stays gone unless they have a reherniation, which is generally the vast minority of patients. On the other spectrum are deformity patients. So there's another patient I treated who you can see has a severe kyphoscoliosis. And this is very challenging surgery, right? So generally when I do these tougher deformity cases, I create sort of a master plan that I have written up on the board. And this keeps everyone in the room, most importantly, myself, focused on the task at hand. But you can see that when you do each of those steps, this ends up being a 8, 10, 12-hour surgery that is actually very grueling. And it's mostly grueling for the patients who take a long time to recover from these. But when you pick patients well and you do the surgeries well, they have great results. And this lady was so happy that she wanted to be on the news. And it was really a pleasure taking care of these challenging patients as well. We also take care of patients when they're really at their worst. So this is a lady who was in a motor vehicle collision, had a variety of other injuries, as you can see, a torn aorta, open pelvic fracture, and a spinal cord injury. And her injury was not only from this, C6-7 subluxation, but she sort of had a double crush injury with this in her thoracic spine as well. That's at T11-12, I believe. You can see significant flexion distraction injury there. So this patient, unfortunately, did not recover neurologic function, but certainly was stabilized, which allowed her to, then be able to sit up and participate in rehabilitation. These are her 2-year films, I believe, showing her alignment. To Dr. Theodore's point, if you want to, cure cancer, we also see a lot of spinal oncology. This is an example of a patient with an incidentally discovered intramedullary lesion, which was an ependymoma. But don't forget that the spinal column is the most common place for metastatic disease to occur. And so, but if you are interested in cancer, good idea to know about the spine, because you're going to get a lot of metastatic disease to the spinal column and patients needing decompression and stabilization procedures. Infectious pathologies happen as well here. So this is a 55-year-old man who presented after falling at home. Not the best protoplasm with, hepatitis and history of IV drug use and endocarditis and a septic hip. But he needed help, and he needed this help because he was weak in his upper and lower extremities, but he also had a holospinal epidural abscess. So you can see there a epidural abscess that starts at C4, continues down through the thoracic spine, causing severe stenosis, and continues down into the lumbar spine. At Oregon, we had the dubious honor of putting together the largest series of patients with holospinal abscesses, and found that perhaps the best way to treat these patients is with skip laminectomies, which is what this patient had. And by 6 weeks after surgery, he stated that he was healed and had no discomfort, had regained his lost strength. And this is his postoperative MRI, where you can see his spinal cord has floated back into a reasonably normal position. Another reason to do, spine surgery is because these techniques are fun and ever-changing. We've got, brilliant people like Dr. Theodore inventing the robot. Now, let's face it, to take out a brain tumor, all you need is a bipolar and a sucker, right? With spine surgery, you have navigation, which has evolved to a robot, which I use a lot in my practice. So thanks very much, Dr. Theodore. There's a lot to be discovered when it comes to spine surgery. And I know a lot of you are interested in research. I would just encourage you to pick up the latest issue of Neurosurgery or JNS Spine, and whether it's clinical research, biomechanical research, basic science research. There's just a lot left to learn for the spine. I really enjoyed the art of medicine when it comes to spine surgery. I think when you see a brain tumor, you got to take it out, or when you see an aneurysm and it's causing a problem or potentially a problem, that you have to coil it or clip it, or whatever is being done now, pipelining and whatnot. But with spine surgery, one of the biggest decisions is, should the patient have surgery at all? And even though I love spine surgery and do a lot of it, I think one of the best things I can tell patients is that they don't need surgery, right? But if you do feel like surgery would be in the patient's best interest, do you do something small? Do you do something big? Do you go front, or from the back, or from the lateral position? What are the different anatomical challenges that come with this approach versus that approach? I'll engage the other panelists right here, and I'll show this case because I discussed this case amongst the Duke Spine faculty. We've got 20 faculty. We spent 1 hour talking about this case, and also presented it for our virtual global spine conference, which I think some of you attend. And 6 faculty hosts gave 6 different answers on what to do with this patient. And so, like Dr. Theodore mentioned, there's more than one right way to do things, and oftentimes the best treatment for the patient is whatever surgery that you're best at. But this is a 55-year-old woman who came in with bilateral hand numbness. She had had her symptoms for a year. This numbness affected all fingers all the time. She also developed electric shocks in her arms with coughing, akin to a Lhermitte's phenomenon. Some bowel and bladder urgency, and some other issues that I've listed there that had since resolved. On exam, full strength, no abnormal reflexes, normal gait. She was a medical transcriptionist actually who loved to bake. So this was her MRI. What you can see here is a pretty large disc herniation there at C4 to C5, causing some severe stenosis with a cord contusion. But as the residents here know, you can never only look at the sagittals, right? You always have to look at the axials. So this is a cross-section of C4 to C5 on the left, which confirms the findings that we see on the sagittal. But you'll see at C5 to C6, she has some, I would say moderate, but maybe not severe spinal stenosis, and at C6 to C7 as well. These are her plain films and her flexion extension films. There was a request earlier to go a little bit slower on the x-rays. So, her AP x-ray shows, pretty straight cervical spine, no cervical scoliosis. And I would say her lateral films show sort of loss of normal cervical lordosis. I would not say that's, actually I did measure her cervical lordosis, it was 0. So it's basically a perfectly straight cervical spine. And no instability on her dynamic imaging. So maybe I could ask Dr. Adagwa, world famous at the UT Southwest, what would you do for this patient?
Well, Khoi, this is a very interesting case. So, you have a lady who's 55 years old, who appears to have myelin radiculopathy, big herniated disc, I think it was a 4-5, and that's causing severe stenosis. And you've got moderate stenosis below. When you look at the spine, the reason she has multi-level degeneration is because she appears to be an axial loader. So this is a patient who probably has a Rousseli type 2 spine. So the question is, if you just decompress at 4-5, she has myelopathy. What about 5-6 and 6-7? So in my hands, I think that I cannot reverse spinal cord injury when it happens. So in my hands, I have a very low threshold, especially in a patient that's symptomatic, to decompress the spine. I think if you only do the herniated disc at 4-5 and she remains symptomatic, you always keep you always reserve the right to go back and do the other level. So I would do the most symptomatic level. I would do where she has the disc herniation at 4-5, because it appears that these symptoms were acute. Based on your presentation, don't sound like this is a chronic problem.
Her symptoms have been for a year.
For a year. In that case, then I think I would treat all 3 levels. I think I would treat all 3 levels. I would go from the front. I'll do a 3-level discectomy and fusion. And the reason I'll go from the front is because it allows you to reconstruct the lower arc of cervical lordosis. And if you ever need to do anything posteriorly, at least the architecture of the spine has been respected. So that's probably what I'll do, a 3-level anterior cervical discectomy and fusion.
Right, maybe I could ask Dr. Theodore if you agree or if you do something a little different.
1 level.
1 level.
Yep.
ACDF?
Yep, 1 level from the front. That's what's causing her symptoms. And there's the reality is, and I agree, we show that, you can, this is where, people can overthink things and whatnot, but the proximal cause, I think most of her strife is at 1 level. We cannot change everything. With every additional level comes additional risk. The other levels, while there's some mild compression there, her problem is that 1 level, and I would do that. And if you do 3 levels, there's a chance you're going to come back. If you do 1 level, there's a chance you're going to come back. But your quickest way to get her better, and the shortest amount of recovery time, is just to do that single level.
Karthik, my old friend who looks like he's at the Taj Mahal. Would you do anything different?
Probably 1 level.
1 level, and
address the current symptoms and go from there.
And lastly, Neetan, Dr. Argawa.
I think those are both eloquently said, but I'd have to agree. I probably would just do the one symptomatic level from the front.
Okay. All right. So when I talk about this case, right? So the things to think about are: do you go from the front or the back? Sounds like everyone here agrees, from the front. How many levels? Obviously, that's spurred on some conversation here. 1, 2, 3. If you do one level or 2 levels, do you do ACDF or arthroplasty? Her cervical spine's reasonably aligned, and no dynamic instability. Do you do the artificial disc, or do you fuse her? Do you approach this from the right or from the left? I trained where if you're a right-handed surgeon, you come in from the right. A lot of people think that coming in from the left decreases your risk of recurrent laryngeal nerve injury. I've heard some people approach from the side opposite the radiculopathy because it's easier to reach that way with the kerrison. If you do 3 levels, do you do a transverse or a longitudinal incision? What's your graft choice? This is something that's really of interest to me, which we won't go into today. If you do fuse, do you do a plate or do you use a standalone device? There's so many things to think about, right? And so what did I do? I actually asked the patient. So I said, I think most of your symptoms are probably coming from, I said, most of your symptoms are coming from that huge disc at C4 to C5. But, I think that there's a small but possible chance that you might still have some symptoms from 5, 6, 6, 7. So really the choice is yours between, 1 hour, 1 level surgery versus a little more extensive, 2, 3 hour surgery for 3 levels. And she actually wanted to do 3 levels. I'm actually seeing her tomorrow for her 1-year visit, but her pre-op symptoms were entirely improved. I mentioned she loved to bake. She wasn't able to do that before her surgery, but made our team a couple of trays of delicious cookies there. And these are her post-op films. So why spine surgery? Simply put, and I'll end the way Dr. Theodore started, but simply put, spine surgery is the best subspecialty within neurosurgery. And I think really with good patient selection, you have great patient outcomes. And, I think one of the frustrating things for me about cranial surgery is that, obviously dealing with people who need help. But let's say, for example, glioblastoma, right? When I started residency, we quoted patients average expectancy after, surgical chemo and radiation therapy of 14, 16 months. We've got the world's most brilliant people trying to cure this, and I would suspect that 13 years later, that average life expectancy has not changed much, right? Similar with aneurysms. Huge problem. We quoted patients, 40 or 50% don't even survive the aneurysm rupture, and only 1/3 of survivors make it to normal. I think with spine surgery, which covers a wide variety of pathologies with tons of different anatomical and technical nuances, we can make a huge difference in the lives of patients. So I think that if you have interest in this, I'd highly encourage you to attend our spine section meeting, which is in July of 2021. We recently moved it from March in Miami to July in San Diego. Most submitted abstracts get accepted for oral presentation. And if you're not wanting to come and speak, it's a great opportunity to come and just learn. Highly encourage you to do that. And thanks again, Jeremiah and the Young Neurosurgeons team for inviting me to speak.
Thanks, Khoi. I noticed you didn't ask me what I would do on that case, So I appreciate your confidence in my spine skills, my friend. No, because I would have just said do a pipeline. So I'm glad you didn't ask. All right, I'm going to introduce our panel. I have a lot of questions, but I'm going to defer this to our spine gurus. Let's see here and introduce everyone. So Karthik Madhavan, he is the Director of Minimally Invasive Spine Surgery at Sanford Health, North Dakota. Welcome, Karthik. Oicho Adogwa, who is been now 1 year at UT Southwestern as an assistant professor of neurological surgery, a subspecialty in spine, and Nitin Agarwal, who is the current chief resident at University of Pittsburgh's neurosurgery program. Did I get your name right, Adogwa?
You did. You crushed it.
All right, excellent, excellent. So I have questions, but I want to make sure you guys all chat it out as spine gurus. Any questions you have or comments you want to make, having kind of put yourselves on course to spend your life doing spine surgery?
Well, I'll tell you, that I sort of I couldn't agree with Dr. Theodore and Khoi. That spine surgery, the breadth and the depth and the opportunity to move the field forward is just absolutely tremendous. I had a mentor, Joe Chang, who was my inroad to neurosurgery, probably one of the best human beings that I know. And I wanted to be like him as a medical student, watching all the complex things he did, and got an opportunity as a medical student to get involved in research. And actually, during an interview with Dr. Theodore many years ago, we began talking about using patients' biology to move the field forward. And I remember as a resident thinking about that, how do we move beyond blue screws and red screws? How do we really move the field forward? And as a faculty member, that's what my lab does now. So I think there's a tremendous opportunity not only to affect to design implants and robots to improve spinal cord injury, but there are a lot of questions we still have. Why, when we think about personalized medicine and spine, how do we identify the optimal candidates for surgery? Why do we still use chronological age for preoperative risk stratification? How do we use a patient's own biology to predict postoperative complications? And my particular area of interest is the older adults, so patients over the age of 65, and there's a tremendous opportunity with all these patients living so long to really improve outcomes in that regard. I couldn't agree with the speakers that I don't think there's a subspecialty in neurosurgery or in medicine that allows you to do the breadth and the depth of what we get to do every day in spine surgery.
Perfect. Nitin, I think you're next in the, no, Karthik, you're next in the seniority chain. Sorry. Any comments or questions or conversations you want to have?
I 100% agree with both the speakers. It was a great presentation. And my question was for Dr. Theodore, how did you actually conceptualize coming up with a robot? And, I have used the Globus robot, and we have one here, and it's probably the best robot that's currently in the market of all the ones that they have out there. So I just want to hear from him, how did he actually conceptualize, and how did it came to being, and how did he collaborate with the company and so forth? A little bit on that.
Sure. Thanks, Karthik. Well, it's very interesting that I grew up right at the cusp of the beginning of image guidance. So as image guidance was first being rolled out, I remember as a junior resident opening up somebody's head, looking for an abscess, not finding it, going to CAT scan and finding out we were a centimeter away from where the abscess was. And that's how everything was done. So I'm dating myself by telling you that story, but it was a pain in the you-know-what to take somebody to surgery and not find what you were looking for. And that happened every day. Once image guidance came out, I loved the fact that that changed everything. That was probably the single biggest advance in neurosurgery and really revolutionized the field. But what I realized, and we started using it in spine, and it was sort of difficult, the registration. But interestingly, the other problem was you're holding that probe there, and everybody's eyes are looking over at the screen. And I realized that there was just a loss of attention. So the same thing when you're on your cell phone and you're driving, we get distracted. So Neil Crawford, who was the head of biomedical engineering, biomechanical engineering at Barrow, over the course of 10 years, 15 years of having coffee every day at the end of the day at Starbucks, I said, Neil, why can't the robotic arm take me to that trajectory and just go there? And he goes, well, of course it can do that, but it's difficult. Anyway, long story short, we approached the foundation at the hospital. They were not interested. And the CEO of the hospital also invested $600,000 for us to be able to build a prototype. And then from there, it's a matter of getting intellectual property and doing everything the right way, because I wanted to publish all our early results. But if you publish it, you can't, it doesn't become commercializable. Anyway, long story short, we were working in the basement for years, and we're able to come up with a prototype. David Paul, who's the CEO of Globus Medical, I think saw that this was what he felt was going to be the future of spine surgery. So we got acquired pre-FDA, and it's become very successful. And I appreciate all the kind words, but it really has been a labor of love. And this is just the start. So it's people like yourself and Khoi who are using this on a daily basis now, who are going to be pushing the next generation. So we're going to be teaching the surgeons how to use it. But I look forward to speaking with each and every one of you guys about how do we take this to the next level. So that's been a very special part of my life. But again, it all comes down to spine surgery. There's just so many opportunities for us to advance the field.
Thank you very much. Can I ask one more question, JJ?
No, Karthik, of course you can.
For Dr. Khoi, my question was, he had already a very successful career in Oregon, and what was the opportunity that led him move from Oregon to Duke? And how would you choose a new university or a department, and how do you go about it?
Yeah, that's a great question, Karthik. Thanks for asking it. I think Oregon was a great program, and I really actually valued being home after having spent 16 years away, like everyone else does, right? My parents are there, 2 out of my 3 sisters. I've got, my dad has like 9 siblings, about half of whom are in Portland with, all their kids. And it was a really, really tough decision for me, actually. But ultimately, I said in my disclosure side that I'm really passionate about neurosurgery and spine surgery in particular, right? And I think at Duke, I found people who are very, very like-minded and who share that passion. And John Sampson, who was the chair at the time I was recruited, and Chris Shaffrey, who's my boss within spine surgery, shared the same vision, which is to make Duke the best, right? And it's going to be hard to be the best when there's places like Hopkins and places where you're at. But to get close would be really, really good, and to be part of that, I think, was really, really inspiring. So that, in short, is kind of why I moved across the country to the South, and it's been a great job so far.
All right, Nitin.
Thank you.
I think your turn to quiz the panel or insert your thoughts or comments on the subject.
Well, as the youngest of the group, with the most hair, I want to know from Dr. Than, 1, how do I get an amazing haircut like you? And 2, you've had amazing trajectory, you had an awesome fellowship at UCSF, and an awesome job. So what's the one thing that's led to your success, do you think, that the young guys like me can benefit from, or with that knowledge and pursue on our own?
To answer your first question, just a pair of clippers and a good wife will do this. I think you're married now, right?
No, just engaged. She hasn't committed. She's still deciding.
Okay, well,
the number 2 guard on the hair clipper, Nitin.
Yeah, don't ask her to shave your head till after you're married, and it's a done deal. But I think you want to be wary of saying yes to everything, but I think saying yes to most things and following through and developing that reputation, I think, is how to really have a fulfilling practice. So very fortunate, like all of you, just to be in general really happy operating, and loving teaching, and super passionate about research, and being involved in organized neurosurgery and spine surgery. So I would say just seeking out those opportunities and doing a good job with those would be the key.
And then Dr. Theodore, I think I come up with a new idea every day, and I get a whole bunch of people who shoot it down for various reasons. What do you think is the best way to hit home on a great idea and realize that you have a good idea and move forward with it and pursue the right path and pursue the right people to get your invention from idea to reality?
So, I mean, I think the first and foremost, you got to believe in yourself and the idea. And it's interesting that in my bio for years, I wrote, you know, interested in trauma, this, that, and robotics. Everybody goes, what the hell have you ever done in robotics? But writing that down, knowing that I was working on the project was my little subtle way to be able to, in my mind, solidify the fact that I had been working on it. But everybody looks at me and goes, you never published anything in robotics. What have you ever done in robotics? You know, that's what I'm interested in. It just says he's interested in it. It doesn't say you have to do it. But the most important thing, I think, is finding the right people to collaborate with. That's the most important thing. And, you know, we'll tell you that the robot story is a whole story in and of itself. I mean, if I could, every single turn, there's something that could have gone wrong, to, you know, but to get something commercialized, to get something into humans is difficult for sure. It's a huge joy when it happens, but you've just got to align yourself with the right business person, the right science person, the right IP person, and just sort of navigate that one step at a way, making sure that you're protected from an IP perspective, you know, and the problem is, you know, people, you know, when you disclose an idea, it's very easy to say, oh, that's stupid. That's never going to work, you know, because I heard that 100 times. So if you believe in something, you've got to believe in it, and you've got to be able to affect that dream by, you know, again, talking to the right people, getting the right team built. You know, I remember the first day I walked into a spine company with a prototype of the robot, and the guy looks at me and goes, what's your business plan? What's your 510K pathway? And I'm like, I don't know. And I walked out of there completely demoralized. In that room was a vice president of the company who named Mitch Foster, who quit his job next week to come on as our CEO because he believed as well. So again, it's just meeting and coming to the right people. And I think that I'll tell you one last piece of advice. There's a phenomenal book by a Stanford business professor called The No Asshole Rule. That is my lifelong mantra, that book. And it basically talks about that word, asshole, of, you know, because we know who these people are who can disrupt, derail, and throw us into a bad situation. That was a company handbook. I handed it out to everybody in the company, and for every company I've started after that, that's been the mantra. You want to surround yourself with people you like and enjoy working with. Then it becomes fun. It shouldn't be, you don't want it to be an arduous thing. It's got to be a passion. And I think that being with the right people and taking that idea, so don't let the naysayers get you down. You can definitely do it. You've got to believe in yourself, and then you've got to align yourself with the right people. And if it's a great idea, then call me and we'll do it.
Lastly, Dr. Johnson, are you thinking about switching your specialty? I know you chose the wrong one.
Every time they call me in the middle of the night for a stroke knitting, you know, I get closer and closer to you guys' side of the neurosurgical table, my friend.
Web.
But then the patient walks out of the hospital instead of goes to the nursing home, and it's quite rewarding. But I'm just kind of joking. All right, very good. I do have a question for Theodore and Dr. Tan. So 10 years from now, what is the field going to look like? I think that, you know, there's a couple of different subspecialties where innovation is booming. I think endovascular for vascular neurosurgery has 20 years has gone from zero to amazing. I think functional is having a renaissance. And I think spines is the other place that I've seen that. So with the rapid development of the approaches, the fusion techniques, the understanding of, you know, deformity, robots, image guidance, what is someone who's just starting their training now what is the field gonna look like when they finish?
Well, much different than it does now, that's for sure. I don't think we're going to be going backwards. I think when you know, the real question is what sticks and how do we, you know, what is actually going to change it. So technologies come and go, and for sure, you know, I remember, you know, being junior resident at the BNI, and there was a television screen mounted in the operating room, and I said, you know, what is that? And they go, that's the Kelly brain system. Pat Kelly from NYU had this sort of stereotactic system for brain tumors, and it was fixed in the room, and it just stayed there for 30 years after it sort of lost touch. So, you know, the real question is, we are being bombarded by, you are correct, technologies in every single field. Endovascular now is a robot. I mean, there's going to be, you know, things are going to change. Part of the issue, I think, is this: we don't have as much time with our trainees. So when I look at spine surgery, I can tell you, I believe that something like robotics is going to become incorporated, because we can do things faster, more accurate, and I can teach people to do that in a more reproducible fashion. Every other thing is we'll have to wait and see, but it's hard to think that with all this stuff, we're gonna take a step backwards. The secondary question is who's going to pay for it, and does it really affect our outcomes? Those are broader questions, but those are all areas of research. Every one of those things is a potential career in neurosurgery, whether it's a cost value analysis or an outcomes analysis or a technology push. So, I mean, the reality is that this is so exciting now when I see the things that are happening every single day in our field. To your point, across the board, I think that really it couldn't be a better time to go into neurosurgery.
I agree with those points very much. I think the things that we'll see in spine surgery in the next 10 years I think we'll probably see the development of a surface technology or biologic that always heals. Right now, pseudoarthrosis can still be healed after fusion surgery. I think we're going to see developments in, Dr. Theodore and others robots to be able to actually do some of the more challenging aspects of cases. For example, like osteotomies around neural structures and whatnot. Do those in a safe manner where there's minimal blood loss and injury to the patient. And I think another thing that we'll see is sort of advancement in machine learning, artificial intelligence type things where given a patient and their profile and their imaging and whatnot, we as surgeons will be able to state with greater confidence exactly what surgery that they need in order to get the desired result.
That's great. One more question for Dr. Theodore, and then we'll move to some of the other questions. There's some good ones in the question and answer. I'm actually quite fascinated by a lot of the people like yourself who've come through the military route, like Dr. Ellen Bogan's, another one comes to mind. It would seem that, if you go and spend a fair amount of time in the military, you're kind of you're starting your career not quite as in the mainstream of academics. And then you come out of the military and get into academics, but you've had, and many other examples of extremely productive academic careers going through that route. Although you would fundamentally, just me thinking about it, I would think that would put you at a disadvantage because your peers are, publishing and getting ingrained in research and whatnot. Could you talk briefly about what that experience was like for you and what you thought you got from it that served you so well in the long run?
So, thanks for asking that. Here's the bottom line. I joined out of sort of a necessity, right? So, I got to medical school at Georgetown. It was the most expensive medical school. I thought, well, they're offering to pay for my education. And, the reality is it turned out to be one of the best decisions I ever made, not just from the financial aspect. I think that part of what you learn is a little bit of discipline. You learn that as a neurosurgery resident too, for sure. But from a team and a leadership perspective and functioning in that team environment, because what is research now? So this past year, I was lucky enough to get awarded a $14 million grant from DARPA to devise ultrasound technology for spinal cord injury. I was a government major, remember that. The bottom line is, though, I'm now leading a team of ultrasound engineers, electrical engineers, in putting together the pieces to move this project. And that is a skill set that is different than that you're going to learn writing a paper. So I think that's, for me, that's what I got. But you can get that anywhere, and those skill sets. Those are learned by having good mentors. I mean, I honestly was blessed. Those 5 individuals I told you, each and every one of them, really had a tremendous impact on me. And I urge all the people on this call, all of us, and you and Khoi, we all have our mentors. We were talking about them before. Those are the people that help us become who we are. And if there's not somebody readily available, seek somebody out, because these are the people that help you transform. You mentioned Ellen Bogan, and I'll finish with that. When I was in the Navy at Bethesda, in this, sort of blue collar residency program, I went out to Phoenix for a year as part of my research. At that time, Spetzler asked me to stay. He goes, "Can you finish we want you to stay. We were getting busy. We'd like you to stay." And I was like, it's like winning the lottery. I go to Barrow, I get to stay, right? The Navy said, "No, you can't go." Ellen Bogan had just taken over as the chairman of the Combined Army-Navy program and told me, he goes, Spetzler offered you a job? I said, yeah. He goes, I'll get you out. Take it. So he got me out to be able to train there and then go back on. So, you know, again, that's a little bit of a, you know, a unique story. But the reality is that, you know, it's not just the military. I think we're all exposed to good people, and the opportunities are there for each and every one of us.
Perfect. I want to second your comments about having a great team that you enjoy working with. You know, the toxic people, I highly encourage people to avoid those if you want to have a good team dynamic and really move things forward together. I would strongly second that. All right, I'm going to bring Anna, who we haven't introduced, but she's a medical student in Mexico and who's helped co-found this webinar series. And she has traditionally taken the role of asking us, or asking you guys, the questions from the audience. So I'll bring her on. And so any questions that you wanted to, from the question box you wanted to ask them, or any from yourself?
We have also questions that were emailed to us.
Oh, yeah.
Yeah, we have, what would you tell students is the most exciting part of spine surgery? And how does this subspecialty compare to others?
And could you repeat the question? You broke up for part of that.
Oh, yeah, sorry. What would you tell students it's the most exciting part of neurosurgery, and how does this subspecialty is compared to others? Could you hear me well?
Yes.
Okay, sorry.
Yeah, I can start. You know, I think the most exciting thing about neurosurgery, brain and spine, is that we're really manipulating with our own hands. You know, very high stakes territory, right? You know, one wrong move in the brain or the spinal cord can absolutely you know, devastate a patient. So it's I think it's probably something that can't be said about any other area, at least not that I can think of, you know, at the top of my head. And so it really requires a lot of, obviously, a long training and practice and skill.
And any other questions that you have?
Yes. In your opinion, what is the required skill set for being a spine neurosurgeon?
Well, I think, you know, rather than a skill set, I would say it's an interest. And it's interesting in neurosurgery, I mean, most people who go into neurosurgery, the majority, want to do brain surgery. That's sort of why we all go into it. And, you know, then you get exposed and your path takes you into whatever, peripheral nerve surgery, spine surgery, whatever. So I don't know that it's a specific skill set. I think it's a passion. We all do better when we do things that we enjoy doing and that we feel that we're good at. So I think that, you know, again, the path really is one that you get to choose and design, you know, the training that you want to receive and getting to do the things that you want to do. So again, it's you know, it's like picking specialty of neurosurgery. It's the same situation. Plus, we have a fit. We tend to, you know, to hang around people that have a similar interest, and why is that in one thing or another? But I don't know. But once you get bitten by the bug, that's it. So
Perfect. Any other questions, Anna?
I have one, but it's kind of like the first one. But what is, you know, the part of the job that you like the most as a spine surgeon? What is it that you like?
Khoi, maybe you can tackle that one.
Sure. You know, I think I mentioned this a little bit, but I just like that in any given week I can be doing a variety of different things, and that's not always the case. You know, I think there's some you know, spine surgeons out there, for example, who do only like lateral surgery, right? Just every case is like a lateral surgery, or what have you. Every case an ACDF, for example. But I like that, for example, in a given day, a given week, I could do a variety of different things, just like my day today I mentioned during my talk, but can range from something quick and easy, like you know, 30-minute case to something that takes, 10 or 12 hours to complete.
Dr. Theodore, I think you mentioned in the questions, but it's probably a good topic to bring up, which is why would someone who hasn't started residency training yet choose neurosurgery for training over orthopedics and going to spine through orthopedics?
Well, yeah, so I answered that in the chat. The reality is, if you're really interested in spine, I think you have a much greater breadth. So if we look at that very carefully, the orthopedic surgeons don't do anything intradural. They're still to this day, sometimes they're getting called by when they have a CSF leak for us to come in and repair the dura. So that happens. But the reality is that, I think your opportunities are greater because we really get to do more things. Craniocervical junction things or orthopedics. And just when you look at the numbers, if 60% or 70% of what we do in residency is spine for 7 years, that's about 4 years of primary spine training. Your board certification certifies you as an expert in spine surgery once you finish. Whereas in orthopedic surgery, you may only get a month or 2 or 3 months of spine surgery, unless you're at a place like Duke or maybe Hopkins, but they all are required to do a fellowship for a year. And I will tell you that right out of the box, you're much better trained than the average orthopedic surgeon. Now, at 5 years, maybe the playing field's level for sure. But coming right out of the box from a breadth of specialty and training, neurosurgery is the way to go. If spine is what you want to do.
In that vein, a follow-up question from Robinson Okolo Jr. When do you do a spine fellowship, or do most neurosurgeons able to do spine right out of the training? What is the nuance to that decision?
So it really depends on where you train and what you want to do. So I think if you are at Duke or Hopkins, I don't think you need to do a spine fellowship. I think you're going to get great primary training. The only caveat to that is if you're really interested in academics, I think it's a very, very good thing to do and a very powerful tool, because you, number one, get to be exposed to just a different place and a different way to do things, a chance to build up an academic portfolio. So the doing a spine fellowship has a lot of great opportunities to it, for the right person. But then you're adding an extra year. But I don't think there's a downside to it, especially if you're going to go into academics. Yeah,
I would agree with that. In most big places, you get the exposure you need. High volume spine places, but it does boost the academic career. And my editorialization would be, yes, if you're at a less busy place or somewhere that's not exposed to minimally invasive surgery or some type of surgery you want to learn, the fellowship is the way to go. That coming from the vascular person, so my apologies. Let's see. Go ahead.
Would you consider infolded fellowship equivalent to an external fellowship when you're recruiting somebody for an academic position?
So, the reality is that, it's very interesting. Yeah, the answer is yes. I think an infolded fellowship is fine. Once again, depending on what you do, where it was done, and what your overall the caliber of that person, and what their contribution is going to be in the research level. I'm not going to be hung up on a piece of paper. So, whether it's infolded or not, I think I would consider them both equal. It's just that shows there's a demonstrated interest. The infolded is an interesting concept. I like it. People are like, well, it's not the same thing as a real fellowship. It depends.
All right. Any other panelists have any thoughts? There's more questions, but maybe one more, which is kind of interesting. Question: is there any particular surgery that's difficult, you find to be difficult, and you'd rather avoid being the operator, and wish someone else would do it? There's essentially a surgery that drives you crazy, you don't want to do when you see them coming.
Tarlov cyst. Next.
Well, Jeremiah, this is Awicho here. I think that the fellowship question is an interesting one, and I as someone who did an unfolded fellowship and a postgraduate fellowship, what I realized as every opportunity to learn from, and I did a postgraduate fellowship in orthopedics. I learned a tremendous amount each of those years. As a fourth year and a fifth year, when I did my unfolded fellowship, the way I looked at the spine, thought about the spine, thought about patient care was very different. I was a very different person in my fifth year when I did my unfolded compared to when I did my postgraduate fellowship. And even after my postgraduate fellowship, there were still questions. There were still questions that I had about how do you reconstruct the spine? How do you think about some of these different things? And I'll tell you, the person who has had probably one of the most profound influences in me as a spine surgeon is Pierre Rousselet. You know, I thought going there was just going to be, I wanted to learn a little bit more about his classification, but really changed the way I think about the spine and alignment principles and all those things. So I think if in doubt, and if you have time, you don't have a wife, you're not being pressured and so on, you learn a tremendous amount from when you spend time with people who've done this for years upon years upon years. There's a lot of nuance to really helping these patients overcome the disease process and have a good outcome. And the nuances matter in this game.
That's a great comment. I love it. I did 2 fellowships, so I'm also not opposed to fellowships. 2 postgraduate fellowships. You learn a great deal. Yeah, you really do. If you really love a particular subdiscipline, if you do these fellowships with luminaries in the field, you just learn so much. And as you say, it's wonderful. And any other questions that caught your eye?
Just one question about the robot. Can I?
Yeah, go ahead.
More questions. Just, Dr. Theodore mentioned about taking the robot to the next level, and I had worked with some of the haptics guys before, but the problem with them was that it took much longer for me as a spine surgeon, if I have to do a fusion, taking out the superior articular process, and that junction where the superior articular process is really hypertrophied and pushing on the traversing nerve root is the key area which needs to be taken out to do any transforaminal or any kind of fusion. And I have felt that the haptic feedback is always there, but right now the current processors are not able to process it as quickly for a drill that's drilling at certain 75,000 rotations per minute kind of a thing, which is why we haven't seen like the facet being drilled by the robot. And I just want to see, like, that was my thought. I wanted to see Dr. Theodore's thoughts on that.
So yeah, there's a number of concerns, obviously, once we put a drill in the end effector. So if you look at the Da Vinci or the master slave robot, we're manipulating suture, we can cut, we can bipolar, we can do very, hand things. The problem with a high-speed drill in an autonomous fashion is that, it's dangerous, right? And that is going to require a significant level of thought before that FDA is allowing, a high-speed drill on the end of an end effector. And I can tell you that for sure, especially if it's done, autonomously or semi-autonomously. I think there's going to be a different way to do that with a robot, and, where we can position the robot such that you can then take the drill down, have the haptic feedback, but have a safe zone that stops you from being too deep or being too medial or whatever. So I think that's a possibility. You maintain the haptic control, and it just like the Mako robot for the knee, consider a no-fly zone where I can paint an area for you, and based on that image guidance that you cannot go outside of that area or too deep. There's always a possibility that something doesn't go well, but I think that's going to be that'll be the entree for that. But it's complicated. But you're absolutely right. There are a number of considerations for that, but it's going to happen. It'll happen in my career, and I'm a little older than you, so.
Okay, that's good news.
Dr. Theodore, someone asked about your thoughts on artificial intelligence in neurosurgery.
Well, since, I have a lack of intelligence, I'm all about artificial intelligence. I think, that it's 100% going to be part of what we do. And, when you look at just somebody like Owicho, who's done a beautiful job of looking at these databases and outcomes for patients and elderly, taking that data and being able to put it into a form such that we can be informed preoperatively. So I've got a project going on right now where we're taking imaging for 20 years of patients, pre, post, long-term imaging, demographics from Epic, and then also patient-reported outcomes into a supercomputer, and then say, hey, 55-year-old guy with diabetes, obese, has this X-ray, you don't need to do T10 to the pelvis. You can do L4-5. And that's all you need to do. And from an outcome perspective, so 100%, to me, that's the end game in what we do. When we're going to be able to be informed by in a learning fashion about how we're doing it, how the outcomes are. That's happening right now. When does it become usable? It's going to take time, but I guarantee that's going to be here to stay.
Yeah, I agree. I think artificial intelligence is going to be a real revolution. I read an article last week that Google's DeepMind entered a 20-year-old contest. Each year they have this contest to try and sort out how you could take DNA sequences and predict how the protein is going to fold that goes through all the different steps to make a protein. And they predicted so they have these series of proteins they know the structure of that they've never published. And so and Google's DeepMind got like 70% correct, predicting downstream folding of complex proteins from the DNA sequence. And essentially, like, the scientists were like, yeah, we're almost done here. This competition is, been solved. And that's really remarkable. I mean, and I can only imagine how that's going to impact our field if it can do something that fundamental.
I think, I fear that, what we want to keep, though, amidst everything else, and I think part of the joy of practicing spine surgery or any sort of neurosurgery is that patient contact. So while we may use robots and artificial intelligence to help inform us, it's still a hands-on situation, and we still have to not forget that bond with the patient and not become, what I don't want us to do is become technicians and not still care for our patients. There was a great article from 1974 called Neurosurgery May Die. And it was an article about how in the early 70s, they thought we're technicians, we really haven't made any advances in anything we do, and that the field is just not going to go anywhere. And I love that article because it's just so wrong. But the fact of the matter is that as we get better at everything that we do, we definitely still, I don't want anybody here, especially the young people on the line, maintain those contact with the patients. Realize that everything that you do, there's another person on the other side of that drape. And our responsibility to that patient to make them better. And that when you have that patient come back who's grateful, when you have that patient come back whose leg pain is gone or whose tumor's out, that's the most, for us, is the most gratifying. So I don't want to, that if that's lost, it's not, you might as well do something else. So
Agree. Couldn't agree more. All right, I think we're going to run out of time there. I'm going to do my little talk on the way out to catch everyone up on what's coming. So thank you for everyone for your participation. We're going to have several people ask questions I think will be perfect for our next session, which is going to be December 17th, and Ask a Neurosurgeon. Any of these questions about work-life balance, how can you prepare yourself to be successful in a match, etc. You can find there. If you get any surveys, please fill them out. We need to get your feedback. You can follow us on social media. You can see the handles there and get updates of all these things. We have a new podcast that we've combined with the Medical Student Neurosurgery Training Center to do, which also has a lot of these similar topics, but in a different format and with different guests. So the people that are watching this webinar may find this helpful. So for instance, our most recent episode that was published is Residency Application Series Applying Without a Home Program. So also we'll have one on international medical graduates as well. Finally, I'd like to mention our new NREF fund that we're going to be trying to fund, honoring Chris A. Phillips, who has done amazing things to help our committee over 20 years. She's recently retired, and we're honoring her great service to our committee in the AANS with an Honor Your Mentor Fund that will go towards funding more resident participation in the Young Neurosurgeons Committee, as well as mentorship for young neurosurgeons, such as medical students who traditionally don't have access to high-level mentorship. So please keep an eye out for that. Finally, all these episodes are edited and archived onto the NREF YNC webinar series playlist on the NREF YouTube page. So you can find multiple prior episodes, and it takes about 3 or 4 days to get these edited and up there. But you can also find these if you missed part of it there. And with that, thank you all very much for joining us. Dr. Theodore, Dr. Dogwa, Madhavan, Ben, Agrawal, and Anna. Thank you all for joining us, and we'll catch you guys in a few weeks.
Thanks so much.
thank you. Great session, Jeremiah. Thanks.
All right. Bye-bye.